it. And we are recording. So I'd like to start by welcoming you all and thanking you for coming at 5 p.m. on a Thursday. I know that can be a bit of a big ask. My name is Josie Ross. I am the Associate Director of Education and Clinical Activities here at the BCCSU, and I will be acting as a moderator today. I'd like to start by acknowledging the territory that the BCCSU is headquartered on, which is the unceded traditional territory of the Musqueam, Squamish, and Tsleil-Waututh nations. I'd also like to acknowledge that I personally am calling from the traditional unceded territories of the Lekwungen-speaking peoples, including the Songhees and Esquimalt nations and the Wasanich Nation. And I would encourage everyone to take a moment to think about the territory that you're calling from and how it relates to this important work. You can go to the next slide, please, Lisa. Oh, so you'll see a quick poll here, and this is just for us to get some quick demographic data to understand where people are joining from, as well as if they are coming from an urban or a rural and remote setting. So we have an hour and a half together today, and we have quite a lot of content to get through. We have 4 amazing presenters. So Zach Madiashin is a nurse practitioner who specializes in addiction care. He is also the acting executive director for the Nursing Policy Secretariat with the Ministry of Health, and he maintains an addiction practice in Nelson, BC. Jenny McDougall is the co-founder of CSUN and founder and lead of the Clean Team. She's a safer supply and OUD advocate and provides peer support to people with lived or living experience. I can also say she's just a fount of knowledge and expertise. Dr. Hanke de Kock is a general practitioner and a member of the CCFP, as well as the Canadian, American, and International Societies of Addiction Medicine. He's a diplomat of the International Society of Addiction Medicine and the medical lead for Interior Health Authority. And Tracy Day is the postdoctoral addiction NP fellow at the BCCSU, as well as the clinical director of the OERC. She has a practice history in Northern BC in developing and providing low barrier care for people who are marginalized by life circumstances, such as homelessness, addiction, colonization, and intergenerational trauma. So as I said, we have lots to go through today, and we're going to sort of set this up in sort of 2 broad chunks. So the first piece, we're going to give you some background and context that I think everyone will be familiar with. We have all lived the last 2 years of dual public health crises. And then we're going to talk about 2 documents that were recently released. So an update to the risk mitigation guidance, as well as a new document, which is the Opioid Use Disorder Practice Update. And we'll also touch briefly on how these 2 documents interact with the Prescribed Safer Supply Provincial Policy, which was released this past summer. And then we'll have quite a bit of time for questions and discussion, but I would also encourage folks, if you have questions as we're going, to just pop it in the chat, and I will sort of pop in when there's a natural lull to ask the questions. Sometimes it's nice to address them sort of while we have the steam and we're talking about it. And with that, I will pass it on to Zach.
Great. Do I have control over the slides, or you do? Okay, great.
Lisa.
Well, hello everyone. I'm Zach, and aside from my bio, I'll just acknowledge I am today in the West Kootenays on the unceded territories of Snag, Silks, and Ktunaxa peoples, and I live with my family in Nelson, BC. So. Lots of slides. I'll try not to talk too fast, but at the same time, get through this and not keep up the other presenters. So first, as noted, we'll be talking about the risk mitigation guidelines. So first, a bit of background. As we recall, there's a pandemic. WHO declared this on March 11th rather, and soon after, on March 17th, was the public health emergency in BC. And of course, this complicated an already strained and terrible situation with our overdose public health emergency that's been in effect since 2016. Next slide. Oh, where's my notes here? I'm following along with my notes. Why was this such a big deal? So we already had the risk of overdose and other harms from the toxic drug supply, but intersecting this were concerns about a pandemic. And so our best minds at the time very reasonably thought well, gee whiz, drug acquisition is a pretty social affair, and so just the meeting up and buying and selling of substances would lead to put at risk for transmission of COVID-19, and further asking folks to self-isolate or quarantine puts them at risk from withdrawal, from not being able to obtain their drugs of choice. And so extraordinary measures were needed to support people who use drugs. And so in hasty but efficient fashion, the first edition of the risk mitigation in the context of dual public health emergencies and interim clinical guidance was released in March 2020. And you know, really we had to respond rapidly and creatively. And so it was impressive how quickly this came out. Next slide. So just briefly, some experiences of prescribers through this time. We noted that some patients benefited from oral Dilaudid and Imeslan, and we did note that in some cases there was reduced illicit opioid use, and folks were able to self-isolate or quarantine for shorter periods of time. I think what we noticed was that for a good chunk of people, the oral hydromorphone and Imeslan in the amounts noted in the document were insufficient for many folks to be sustained on simply that and avoid interacting with their usual supply chain of substances. And so it was not as effective from that perspective, but I think we did have some success with those shorter periods of time of self-isolation. Certainly there's been anecdotes of diversion and negative urine drug screens for the prescribed substances that were reported, so you know, leading to the thought that they may be diverted in that case. Next slide. Sorry, I missed one point there, and I think the other point there that we noted was there was great utility in using oral hydromorphone as a bridging medication for the initiation of traditional OAT. As we know, on-ramping on methadone takes forever if you follow the guidelines. Cadian's faster, but even that can be slow for folks that have a high tolerance. And so using Dilaudid in addition as a bridge did more immediately help people reduce their fentanyl use. Next slide. Sorry, I'll go to the last one. I got out of sequence there. There we go. No, I mean the previous one. Sorry, I'm on a different. I'm not advancing mine the same as yours. This is the danger. Okay, success of the program. Okay. And then just to speak to stimulant replacement therapy, I think we found that it's pretty variable in how it's reduced methamphetamine use. For short periods, we've noticed that it has helped individuals who are exposed to or test positive to COVID-19 isolate and not pursue their methamphetamine. But for longer periods, I think we found it's pretty variable. I mean, anecdotally, I can certainly describe some people, surprisingly, that went from a gram a day to virtually zero on 60 milligrams of dextroamphetamine. But I think it's been pretty variable in how effective that's been. Okay, next slide now. And now I think I'm passing it over to my colleague.
Sorry about that. I think Jenny's not here yet, so I'm going to fill you in on all these slides. So be gentle on me. Background, and these are the experience of people who use substances, and I hope that I get all of this right and would never want to speak on behalf of someone else's lived experience. So I just like to say that in the beginning. So hydromorphone and methadone help somewhat, but they're not efficient for cravings or withdrawals for all patients. And I think, Zach, you pointed that out already. Higher potency drugs like higher potency opioids are needed. And there's very inconsistent access to the RMG prescribing throughout the province. I think we've all heard about that. And peer navigators and patient advocates on the care team can help support engagement in care. And that's true. We all know that we need to have the grassroots approach and have peer navigators really paving our way. Do the next slide. Safe Supply OUD advocacy program. So there are so many programs and things that we can do, things that are out there to offer support, like in outreach and sharing knowledge, meeting people where they are at. And that's truly one of the most important things that I think in practice are relevant, like a trauma-informed approach. So peers could attend appointments with clients, set reminders, have help in delivering medications. And, I've done this through the risk mitigation prescribing, having, to write on the prescription itself, like who's going to pick up the medications, and that's okay, and they're going to deliver it. So I think there's so many things that the peers can do to support, and that's in collaboration with the prescriber and the pharmacy. And then providing support throughout the week. Building relationships, and I think that just speaks to building relationships between all the people involved in the care and bridging gaps. Absolutely. We'll go to the next slide. The numbers vary, but currently working with 53 clients. So 33 are Indigenous, 20 are non-Indigenous, 20 are youth aged 18 to 25, and 3 are currently pregnant. And that's Jenny, not me. The medications involved for Safe Supply and OUD advocacy programs include methadone, she's got 41 patients, or clients rather, Suboxone 7, Sublocade, Cadian, and Dilaudid. So it's nice to see that there's a good number of patients that are on methadone and Cadian and then Dilaudid at the same time. I think that again speaks to what you were saying, Zach, about the co-prescribing. And then, of course, the stimulant Safe Supply. And over half the individuals were diagnosed with ADHD as a child, but again, unmedicated in childhood or adulthood. Referrals have been made to urgent primary care centers, the Westside Mental Health and Addictions, First Nations Health Authority, and support around the app and intake forms, assistance with going to treatment and to detox. Daily medication delivered privately. That, I mean, Jenny goes anywhere to private homes, to shelters, to isolation spaces and emergency shelter rooms. She helps and attends private appointments and advocacy appointments, assists with intake forms and PWD forms, provides reminders for appointments, support if the individual has issues at the pharmacy. And, not all pharmacies and pharmacists are the same. And I think that we really know and value our pharmacy colleagues. They do a lot of driving and finding the individual if they have to go to their home and tell them about their appointment and pick them up. So that's a really time-consuming thing. I'll go to the next slide. Thanks. Successes in the advocacy program include family stability and clients living with their families. So really getting that family function improved. Parents able to visit with their children. Disengaging from criminal activity, that's really high, really great. Decreased substance use and fewer overdoses, including some clients that no longer experience any overdoses. So that's fantastic. And also clients reporting that Safe Supply has changed their lives for the better. Even though it's not at the optimum dose for some people, it is really life-changing. And then, of course, increasing housing security. And the next slide. So this slide is by a nurse, and she's given this statement. While I consider myself new to the nursing care or population affected by substance use disorder and homelessness, I have seen many positive changes in my 1.5 years in the role as primary care nurse for the OUD clinic in Safe Supply. Our program has been utilized by peers in our OUD clinic even before I began this role. I cannot imagine having them. They are directly involved in liaison with the clients in Seasons House, Bridges, and our clients not only in their own spaces in the community, but living in homelessness by encouraging them to access OUD. Peers meet clients where they are at and help them navigate the OUD program by educating them on how OUD can benefit them and helping them with the registration paperwork. They provide safe bridges between clients with used experiences and professional staff by accompanying them into their appointments with the OUD provider. They are instrumental in picking up their medications and at the pharmacy, and they assist by picking up clients who are unable to attend their appointments due to transportation challenges. They are able to spot errors in prescriptions and notify myself so that corrections can be made before the pharmacy closes. And they offer appointment reminders to our clients on a regular basis. They do referrals from their community agencies like CSUN, mental health support, and the housing coordinators at Seasons House, and independently looking on behalf of our clients. They allow us to offer many extra services that we would not have been able to offer, and thus wrapping around service for our clients. And that's by Lenore McKenzie. For medication delivery in this program, it is important because it helps stabilize patient or clients, and clients who miss days or too many of the medication in a row must restart, which is disengaging. Having a peer advocate in the appointment with the clinician and the client helps build trust and a feeling of safety, and they can be open and honest about their drug use. This is by Dr. Engelbrecht. It is great to work with a person with lived experience. She has taught me more about the personal experience of people who use substances than I could ever read in a book. She has acted as an interpreter to another world that I was not familiar with as I thought. Go to the next slide. The gaps in the program. Some individuals have high tolerances, so doses aren't strong enough. Continued experiences of withdrawal and the need for prescribed fentanyl patches or powder. There's not enough options for stimulants. Options unavailable for those who smoke substances. There's need for medications for individuals who use crack cocaine, and individuals need prescriptions if they are withdrawing from benzodiazepines. I agree with all of that. Next slide. And this is future planning. So in the future, Jenny would love to have a partner with First Nations peer and mentor in this role so they can work together to support all community members in a culturally sensitive environment. Zach, you're on mute.
I'm on mute. I'm not on mute now. Thank you, Tracy. So back to, so this just over the changing landscape. So I would say back in the waning days of 2019, we thought that we were getting there. We were turning the corner. The overall death rate was going down from the worst initial years in 2017, and but then with the pandemic and for a variety of reasons, drug supply or supply chain and so forth, with the death count started to increase. And so in 2021, we know actually just yesterday the number dropped, and it was a terrible year. So we have noted increased adulteration of the street opioid supply with benzodiazepine and analogs, which is a serious concern. As we know, co-prescription of those two agents is ill-advised. And so we know that creative and novel approaches are needed to reduce overdoses and other harms. Next slide. So we have had some research occurring in the background here. So since 2020, the Canadian Institutes of Health Research have helped fund an evaluation of this clinical guidance document, and its results have helped inform the updates to the document and to the updated opioid use disorder practice update, which you will also hear about. This was led by investigators from BC CDC, SFU, and the Canadian Institute for Substance Use Research at UVic. They used mixed methods to provide a comprehensive assessment of the impact of this guidance on overdose, and it involved participatory approach to develop and implement evaluation, and partnered with people with living experience of substance use. There's still more evaluation happening, so more results will be released in the future. Next slide. So just briefly, I won't bore you with too many details here, but over 6,000 people were dispensed RMG prescriptions from March 2020 until the end of the study window in February 2021. Opioids, 58%, stimulants, 18.8%, alcohol withdrawal medications, non-benzo, 22%, and benzos, 12.1%. And so overall, nearly 180,000 unique RMG medication dispensations. Next slide. And so interestingly, I think we wanted to know, at the very least, are we causing harm with this approach? So 82 people out of that 6,500 died during that period. 40% were prescribed opioids only, 11% stimulants or co-prescribed stimulants and opioids, 7% alcohol withdrawal meds, non-benzo, 21% were prescribed alcohol withdrawal medications only. Sorry, the previous one was withdrawal medicines and another risk mitigation medication. And then lastly, 21% were prescribed benzos only. Next slide. So this is the interesting part. So 7%, sorry, what slide previous? There we go. So of those 82, 7 had an active dispensation on the day they died, but the remainder did not. So 45% of those who died, the cause of death was not specified, and 55% had a cause of death specified, and none of those details indicated that their death was due to illicit drug toxicity death. So they didn't die from fentanyl or another agent. And among those who died and did not have an active dispensation on the day they died, just look at those average length in days from their last prescription of one of these RMG medications and the day they died. Quite a spread from 41 days to 72 days. So I think we can clearly draw a line that we didn't make anything worse, at least by prescribing these medicines. And indeed, it seems as though we had helped some people avoid illicit drug use. Next slide. And just for comparison, what does the general public tend to die from as far as mortality rate? So per 1,000 person years from benzos, we'll see 27 deaths, alcohol withdrawal medication, 17 deaths, opioid, 11 deaths, stimulant medicines, 9 deaths. So categorized over the 6,000 that we saw, I think we are doing better. And the BC CDC concluded clearly that the risk mitigation prescribing is not a direct contributor to the rising rates of illicit drug toxicity deaths in BC, and that fentanyl and its analogs remain the main contributors to illicit drug toxicity deaths. Next slide. So just a further breakdown on the evaluation, 94% of prescriptions were daily dispensed. 68% had received OAT in the previous 30 days. And among those who had not received OAT, almost 2% received OAT with their first risk mitigation dispensation, and a further 15% received OAT within 7 days. Approximately 50% were not prescribed OAT in the 30 days following their first risk mitigation dispensation. Presumably, that means 85% did. I'll make that assumption. Next slide. So there's 3 documents of note that we'll discuss. I'll immediately get into the 2nd edition of the risk mitigation guidelines, and my other colleagues will review the updates to the opioid use disorder guideline and then the prescribed safer supply policy. Next slide. Next slide again. So the overview or the update was undertaken at the request of both ministries of health and mental health and addictions. And we wanted to update it in response to feedback from prescribers seeking additional clarity and guidance. Sometimes you don't know what was missing until you start using the guidance tool. And so there were lots of notations on that. Consultation included health systems partners, OIT prescribers, and persons with lived experience. And the guidance document is still specific to the context of COVID-19. So that's the clear delineation here. This document is still in the context of dual public health emergencies, as opposed to a true safe supply document. And Tracy will get into that piece later. Next slide. So these updates included guidance on patient planning following an initial medication trial, which was lacking detail in the first version, limitations and uses of UDS, informed consent, some guidance on missed doses for these agents, opioids and stimulants, some further guidance on managing benzo withdrawal, how the role of peer navigators and advocates may fit in. Certainly and relevant, I think, to this group, rural and remote considerations, billing considerations, and also some clinical scenarios. Next slide. So eligibility criteria. We further, well, I shouldn't say we, I didn't write it, but the guideline further provided detail on eligibility criteria. So individuals should require support to physically distance, self-isolate, or quarantine in order to prevent the spread of COVID-19. And they also have ongoing active substance use and a high risk of withdrawal, overdose, craving, or other harms related to substance use. So this eligibility criteria clearly draws a line between substance use and some sort of impact from COVID-19. And that there's a requirement to self-isolate or quarantine. Next slide. We've also in the guidelines noted that youth and pregnant people can be eligible for this. Youth aged 19 and under may be eligible if there's informed consent. Efforts should be made to offer alternative treatment options, and clinicians are encouraged to consult an addiction specialist with experience treating youth and or use of the 24/7 line. Clinicians are encouraged to consult a perinatal addiction specialist or the 24/7 line when considering prescribing these agents in this way to pregnant patients, and certainly arrange a connection to health and social services, and appropriate resources should be offered. Next slide. Further assessment should, for eligibility, should include these things noted. These will all be available later, so I perhaps won't read every slide here, but certainly an active substance use assessment is needed. And a diagnosis of substance use disorder is not required to use these, but certainly these conditions should be in play. Next slide. It's important to note that the risk mitigation prescription medications are eligible for pharmacare coverage under Plan G, Plan C, Plan W, and Plan I. Of course, some non-prescribed substances that are referenced in the risk mitigation guideline, like alcohol, tobacco, and cannabis, are not covered by pharmacare. And so I know that's led to some creative solutions for communities that did attempt a managed alcohol solution to isolation for some folks. And other alternate pharmaceuticals not listed in this guideline may be available through health authority run programs offering safer supply. Next slide. So what's in there for medications? It's still the oral hydromorphone 8 milligram tablets with a range of 1 to 3 tabs Q1H as needed, up to a 14 tab max, and or Messalon 80 to 240 BID provided daily. Daily dispense is certainly preferred. And I think some of us in rural remote areas have needed to be a bit more flexible with that in order to help people. Next slide. As far as stimulants, dexedrine is still in there, 10 to 20 milligrams BID with a maximum dose of 40 milligrams BID per day, and or use of IR 10 to 20 BID to TID with a maximum daily dose of 80 milligrams per day. Ritalin 20 to 40, the sustained release 20 to 40 a day with a maximum of 100 over 24 hours. And of course the IR formulation is listed as well. Next slide. So for benzos, there is some greater guidance for tapering folks while they're in isolation or quarantine. Certainly the second bullet on here acknowledges that sometimes a short-term maintenance is more appropriate, acknowledging that they're probably not going to stop and that a taper may not be indicated, but otherwise there is a preference in the guidelines that a taper protocol should generally be offered. Next slide. For those who are isolating and have alcohol use disorder, of course, we want to assess their risk of withdrawal. So the PAUSE scale is, of course, the standard for this, for severity. Next slide. For those who use tobacco regularly, provision of a nicotine replacement therapy by patch, gum, lozenge, inhaler, and or offering of our pharmacotherapies for tobacco cessation, Champix or Zyban. I'm using the trade names, not me. And consider supporting access to tobacco products where needed. Again, I think we're not trying to necessarily stop people's use, but rather encourage their isolation and quarantine. Next slide. And for cannabis, when indicated, you can consider authorizing cannabis for patients who do qualify for medical cannabis. When indicated, offer counseling for patients using cannabis, and providers should also provide risk reduction counseling. Attempt to encourage people to use non-combustible forms of cannabis, edibles, and so forth. Never lose an opportunity for harm reduction. And for individuals not able to participate in psychosocial treatment for cannabis use disorder, you can consider exploring the patient's interest in learning about other harm reduction measures, such as use of cannabis dispensaries for accessing more uniform product. Next slide. So the risk mitigation update does not provide guidance on initiating medications outside the context of COVID-19. So this is not a safe supply document. As the risk associated with COVID-19 evolves with widespread vaccination, but risk of overdose remains high, it may be appropriate to continue prescribing for patients who have shown clear indication of benefit based on clinical and psychosocial criteria. So that's sort of opening the door to continuation after the more classic eligibility for use of these guidelines are indicated. If patients are benefiting from risk mitigation prescribing, their prescriptions should not be discontinued solely due to reduced COVID-19 risk or having completed self-isolation. The risks associated with prescription medications of a known potency, for example, through diversion, are less than risks associated with the illicit drug supply. Next slide. So here's a long list of indications that we may assess clinically that a patient is benefiting. Of course, stated reduction of illicit substance use, negative UDS for those. A lot of these are patient-driven by reports of reduced cravings, and some are more objectively measured from reduced emergency and acute care presentation, and functional outcomes. I think this is something that we can assess if they're people that we see regularly. Are they doing better? I think that's something that we can definitely see. Next slide. And then psychosocial indications that patients are benefiting. Reduced need to engage in high risk and criminalized activities to support substance use. Of course, this has long been the argument to explore safe supply as a policy. And improve overall mood and attitude, ability to meet goals, pursuing things they may not have pursued in a long time, like education or training programs, employment, interacting with friends and family more, leisure activities, hobbies. These are all good things. Safe housing. Next slide. So I'll end my long section here with just a case study. So here's an example. Sandra, a 42-year-old female, has a visit through telehealth and reports mild upper respiratory tract infectious symptoms. She uses opioids daily and benzos when she can get them. You ask Sandra what she's been doing to keep herself safe in the last 6 months, and see that she does have stable housing. She lives in supportive housing. She's using 250 milligrams of fentanyl IV per day, so 2.5 points, about 3/4 of a gram a day. On average, uses street-obtained Xanax pills 3 times a day. She's not on OIT for the last 6 months. She was previously on methadone quite some time ago, but found the side effects intolerable. She has no history of complicated withdrawal from benzos, no history of seizures, and she has skipped use of Xanax for days without having seizures. But she does feel like she'll need them in order to stay in her room for any kind of isolation. She has declined OAT. So based on this recommendation, what should our treatment plan be? So I'll just jump to the answer. So using the guidelines, we should inform Sandra that she may be at risk of COVID-19 based on her symptoms. She ought to self-isolate at home away from other people, call 911 if she has trouble breathing. We should encourage her to get tested for COVID-19 and provide information on local testing sites. Make sure she has a phone or a phone close by while she self-isolates. Now, what should we do to manage her usage? So for opioids, certainly we could offer methadone or Suboxone or Cadian, which she does decline today. But she is willing to try some of our other agents in the guidelines. So we start her on Ameslan 150 POBID and hydromorphone tablets, 8 milligram tablets, 2 to 4 BID to TID, and we make the decision to be modest with 9 tabs per day and assess later. We're going to have them delivered, daily dispense, but not witnessed. So obviously this is a town that has a good delivery system. That's great, not all our towns do. We discussed with Sandra her ability to stay safe while being prescribed with the morphine and hydromorphone, especially when she is alone. And for her benzo use, she is confirmed to have COVID-19, and we have concerns that initiating a taper while self-isolating will destabilize her. We can consider a 2-week maintenance period to support her self-isolation, followed by an initiation of a taper if she's willing. So a good starting place. I think we always kind of ballpark it with those Xanny bars, but for the case of this case, we could try clonazepam 1 milligram BID, and then assess from there. Again, we want to daily dispense that, not witnessed, and then assess daily for further signs of withdrawal and need to adjust the dose. If COVID's negative, then we can switch to a taper, and of course she's free to leave her room, and we can offer a taper if she's willing. Next slide. So I feel like this is a repeat of what I just said about the sorry, I think my notes on the previous slide all got into the benzo plan here. So there's what I just said, but written down. And I hope that's helpful in articulating the risk mitigation guidelines 2.0. And I will now pass it off to my colleague to go over the opioid use disorder practice update.
Good evening, everyone. My name is Anke de Kok. I have a pretty short section today, so I'm just going to give us an update regarding the opioid use disorder practice update. So initially in 2017, the opioid use disorder, the guideline to clinical management of it was published in 2017. But since then, we've gathered evidence, best practices of care, and also clinical experiences to get us to this update where we are today. This update reflects the most recent and high quality and comprehensive evidence on the full continuum of care of opioid use disorder. Next slide. The opioid use disorder practice update was specifically created to provide updated guidance as the planned update to the guideline for clinical management of opioid use disorder. This has been delayed due to the urgent response to COVID-19, but that being said, we utilize this clinical experience from the risk mitigation that showed patients benefiting from hydromorphine and MS-LON prescribing, providing guidance on when to trial this intervention. So clinical experience indicates that some patients, because of fentanyl, the tolerance is much higher and requires significantly higher OUD doses. Important point, the next one, buprenorphine naloxone remains the first line of treatment, but please consider all three, such as methadose as well as slow-release oral morphine when considering treatment. So this is specifically with regards to microinduction, which means slowly uptitrating the doses of buprenorphine with the cessation of other opiates once we reach the therapeutic dose of buprenorphine naloxone. With this microinduction dosing, it reduces the risk of precipitated withdrawal, and we can initiate people quicker on buprenorphine naloxone because it does not require moderate to severe withdrawal like previously. And this also may be helpful in individuals using illicit fentanyl, as the risk of precipitated withdrawal may be higher in those individuals. This is just an example of a microinduction scale. Hopefully everybody's pretty familiar on this. There's a different variation of this scale as well. I mean, but this is a pretty standard microinduction. Next slide. So since 2017, the publication of the OUD guideline, then this new formulation is available. Sublocade, which I personally use a lot, and then the implantable form of Suboxone, and then also the Suboxone film. Currently, there's two methadone options available in BC. Methadose was first introduced in 2014 to replace compounded methadone, and then Metadol D has been a regular benefit since 2019, and then as of October, Sandoz methadone is no longer commercially available. Next slide. So with regards to slow-release oral morphine, a variety of dosing schedules has been described in the literature. What we've learned since the first publication of the 2017 guideline, it was quite conservative. Nowadays, I mean, for myself specifically as well, I work mostly in a hospital setting. Starting doses can be as high as 200 milligrams commonly used, with an increase of 100 milligrams every 24 to 48 hours. They say the highest dose described in the literature is 1,200 milligrams. I'm sure a lot of people on this call have used higher doses than that. Also, in my clinical experience, that patients often require doses above 1,200 milligrams. And this is just an example of uptitrating of an SROM. Thank you. So I'll pass it on to Tracy.
Thank you. So basically this update limits, so this is about prescribed safer supply, and this update limits the safe supply to MS-LON and hydromorphone, and does not consider these medications as treatment for OUD, or for opioid use disorder. And the prescribed safer supply policy, like a first in Canada actually, here in BC, was a public health measure, and it was released on July 15th with a $22.6 million over 3 years to the regional health authorities to support the planning and phased implementation, monitoring and evaluation of prescribed safe supply services. Essentially, the goal is to separate people who use drugs from the toxic supply and decrease any risk of overdose deaths or drug-related harms. And aside from OUD, MS-LON, and Dilaudid, this act also facilitates access to prescribed IOD and fentanyl products like sufentanil and Fentora and fentanyl patches. And guidelines for fentanyl patches should be out in the next couple of weeks, and then Fentora and sufentanil, I think later in the spring. Hey, Josie, go to the next slide. The criteria for prescribing safe supply are: 1, ongoing active drug use and plus risk of toxic drug poisoning or other drug-related harms. And those would be like high-risk criminal activity, sex work, infections like HIV, hepatitis C, infective endocarditis. And I think the most important thing to recognize here is that you do not have to have or give a diagnosis of opioid use disorder in order to make a prescription for prescribed safer supply. Next slide. So this is going to look familiar to you because it was in the risk mitigation guidelines that were originally made, and they were in the updated risk mitigation guidelines, but now they're part of the opioid use disorder practice update as a mainstay for prescribed safe supply. And so anecdotally, and I think you probably maybe read the chat, where patients have informed me and informed all of us probably that these doses are not often high enough to meet their needs. Like, for example, speaking in the most general way, as the fentanyl concentrations vary so much and are ever increasing in their strength and concentration, the general rule of thumb that I use would be every point of down someone is doing, I kind of measure that as between 3 and 5 Dilaudid 8 milligrams. And I don't know if that makes sense to anyone else, but that's kind of what I do in my head. Jenny can probably correct me in a bit. I'll move to the next slide. So this is the scale I use, and this was developed with a peer colleague of mine. And it basically helps me determine someone's level of drug use. And sometimes if people don't know how much they're using, if they can't tell me they're using like a half gram a day or a half ball a day or whatever they're using, sometimes they can tell me in money how much they're spending. And so this is what really helps me out here. And these prices for this was last September in Prince George. So it probably varies based on location and, you know, what kind of current state like the demand and supply is in. But anyway, if you're newly starting opioids or down, you would start with maybe a quarter or a half paper a week or a day. And by the end of the week, you'd be up to a half point or a point like 4 to 6 times a day. And by the end of 1 month, like you could be up anywhere between 1 gram to 1 ball or 1 half ball daily. And so a person with a lot of experience and a high tolerance may even use 1.5 to 2 grams per shot. And the thing about that is, when I think about that math in my head, if 1 point equals, 3 to 5 dilates, and 2 grams would be like 20 points, that's between 60 and 100 dilaudid 8 milligrams a day. So between 3 and 500 milligrams of hydromorphone that people are like say injecting, for example. So if someone's injecting 300 to 500 milligrams of hydromorphone, the milliequivalence of that is somewhere between like 1,500 and 25 milligrams of morphine. And so you can imagine why we have people that come into the emergency department or the hospital with whatever illness that they may have. And then someone has the audacity to order like 1 to 3 milligrams sub-Q of Dilaudid. Like, it's like no wonder people leave and can't stay in the hospital. It's because I think that like a lot of healthcare providers don't understand like the level of tolerance that people have for this fentanyl, like because of this fentanyl and these opioids. Anyway, I'll go to the next slide. Assessing for the risks or assessing for the benefit of prescribing. Usually the trials last for 2 to 4 weeks, but intervals always vary based on patient location, circumstance, clinic hours, and prescriber availability. And of course, the patient preference. Like, we should always be asking and make informed decisions with our patient partners and whatever we are considering for a treatment continuation. And the next slide. So the benefits for patients looks like things. So reduced cravings is what I would ask for. Reduced withdrawal symptoms. Like, are you having any reduced use of the street drugs? Are you having less or no overdoses? Or just like, I just want to know, are people feeling better? Are they just having a better sense of well-being? And then I also want to know, like, I want to sense if they have like just a better attitude towards themselves. And I also want to know maybe if they're having reduced risky activities or criminal activities to obtain drugs. And then maybe if they're accessing other healthcare services. Go on to the next slide. So, like for evaluating and monitoring. For monitoring, we check PharmaNet with every prescription that's initiated or refilled. And part of this evaluation program, we need to use the tag SA, so safer alternative, on every harm reduction prescription. And this will allow for the data to be easily pulled from PharmaNet so we can really know what's going on and evaluate what's happening. So I think we can go on to the next slide. I guess the other thing that I wanted to say is just reiterate what Zach said, that the coroner also clearly states that the risk mitigation prescribing does not play a role in the overdose death that is caused by the illicit drug supply. Fentanyl is doing that. The increasing serum concentrations or the increasing concentrations of fentanyl and the analogs, that's what's causing the overdoses and the deaths. So I'm on the next slide already. Okay, yeah. So this is Aaron, a 39-year-old guy. He comes to see you, tells you that he's trialed morphine when he was isolating for COVID, and he's concerned about an overdose risk. So he's really not interested in OUD, and he just wants to continue on. So he has significantly reduced his cravings, and he has a fixed safe house with his partner. He is able to safely store the medication. There's no kids around. He doesn't use alcohol or benzos, and he has previously overdosed, so we're a little bit worried about him. And his goal is to reduce reliance on illicit opioids. So when you think about this guy, we can think about a treatment plan that uses motivational interviewing, and then really work with him on a plan to have a goal of stopping illicit opioid use. Well, I don't know, if that's what he wants, sure. And then we would prescribe him some oral hydromorphone, 8 milligrams, 14 tablets a day. And on the prescriptions, I usually put, 1 to 3 tablets Q1H PRN, and then I always put on there IV, PO, or intranasal, because I want to make sure that however patients want to use it, they are permitted to by like the prescription. So in case they're staying in some place where they would get like in trouble or kicked out or whatever, that they actually have that written on their prescription to use it that way. So anyway, we would do this for a trial of 4 weeks and schedule a follow-up at the end of the period to see how, if Aaron wants to continue this or not. So now I just want to go to the good part, I think, like the more realistic part, because this is actually what we need to talk about and what we need to consider when we think about working in rural and remote areas. Oh, maybe, can I go on to the next slide? Thank you. Okay, so I had this lady come in. She's a 45-year-old Indigenous lady who is in Prince George, and she came into the OUD clinic at the OPS and the safe consumption site, and wants her prescriptions refilled for methadone. She's currently on 60 milligrams daily, as well as hydromorphone 14 tablets and gabapentin 600 TID. And she's requesting that we give her a prescription for like 10 or 14 days of all these medications, because she needs to go to her reserve because she's in danger. Her ex is getting out of corrections and she's worried for her safety. And her only opportunity to leave is leaving that night. We'll go on to the next slide for some more information. So upon further assessment, you find out that obviously she has opioid use disorder and stimulant use disorder, and she's also had chronic pain for years. But she restarted OUD 2 weeks ago, and after that, or she started OUD 2 weeks ago because she was having so many overdoses. And since being on OUD and safe supply, she has decreased her fentanyl use from 1 ball a day to 2.5 grams a day. She hasn't had any overdoses since she started on these medications, but she still has been having blackouts. So she has ongoing cravings for opioids and stimulants. And of course, she, like I just said, she is continuing to use like 2.5 grams a day IV and smoking, as well as some crystal meth, 0.5 gram a day. Her urine, drug screen, and Pharmanet are all appropriate. She's living in a shelter or outside in Tent City, kind of back and forth. And the other information is her reserve is 5 hours away from Prince George, and the closest pharmacy to her reserve is 2.5 hours away down a dirt logging road. The host that she would be staying in is a multi-generational home, including children. And in her small community, there is no nurse at the community health center. So I think this is where I'd like to open it up for discussion and to see if you have any questions or suggestions.
Jenny here. I was wondering, I just had a thought about this, and I'm wondering, like, so if you do say yes to giving her these medications, if we could acquire a lockbox and maybe the doctor could check in virtually while she's there. And if there's somebody safe in the house, like a grandmother, if it's multi-generational, or mother or sister, that you could also check in with them to see how she's doing on the medications.
Yeah, those are fantastic ideas. Mm-hmm. I 100% agree.
Or a peer could even be visiting if she has a fellow peer that's close, or doing virtual support too.
Mm-hmm. That's great information. Wonder if anyone else has challenges or, you know, when you see the guidelines and you see daily dispense and she's still titrating up on methadone and she's on safe supply and everyone wants that daily dispense and the methadone daily witness. So where do we sit and how do you move forward with this? I'm just going to look in the chat to see if anyone's. Jenny thinks it's a lot more than 5 daily aids that equals 1 point, probably now.
Like when I used heroin, I used to use dillies if I couldn't find any heroin, and I would do like 3 or 4, and I would feel unsick from being dope sick on just heroin. But with the fentanyl, it's just so much stronger that I watch people do like 10 at a time and they're still sick. They're not even feeling it. But when they do a point, they're totally fine.
Yeah. Yeah. I've seen that too before. Is there anyone in the audience that would struggle with giving a 2-week prescription of Carrie's?
I wrote in the chat, can everyone hear me? I had a similar case because I work up at an OUD clinic in Pemberton, and we actually have clients from farther away. And we had a similar case, but it was Cadian. So I was, really reluctant, but the mother did live with the adult daughter, so there was someone there. So I felt that that was okay. And we're also available by Zoom. So I did like a Zoom check-in with the client and the daughter about a week later. And they actually had Cadian and some Dilaudid as well for breakthrough. Yeah. So it's really tough, but sometimes, if people can't get to the pharmacy, they have to be a bit more creative.
You really have to have that risk benefit worked out, hey?
Yeah, because, I find if people are in communities that don't have drugs, like myself, and when I was using an entrenched addiction, I would find something, no matter what it was. I would not stay sober. So whatever I had to use to get high, I would use. And even if that's stealing my grandmother's medication or running away and hitchhiking down Highway of Tears to get where I need to be.
Yeah. Would anyone else like to comment on this case? Sharon says, naloxone kits for everyone trained in the household. Ask about benzo use. Make sure she has access to a phone. Frequent check-ins. It's really stressful dispensing 2 weeks, especially a small First Nations community, or coping with lots of overdoses. Sometimes there is also pressure on the person to share their safe supply. This is really hard. It is really hard. And we know people share their safe supply. I mean, that's part of being safe.
Yeah, I would rather share mine than have my friend try and go get benzo-laced fentanyl and maybe die, right? So I know that's an issue with prescribers though, and I don't want anybody to lose their license and stuff because of diversion. And I understand the fear about the overdose and stuff like that as well. I just feel like with drug users, like we usually share our illicit supply as well with her, if our friend is sick or.
Yeah. That's very true. So maybe I'll hand it over to Josie if she wants to continue on with her program.
Thanks, Tracy. I'm wondering, Tracy, what would you do with this woman in your clinic?
Oh, I think I would do exactly what Jenny suggested. I would ask what her supports in the community were, and then go on to find out what the safest approach is. And then we give her this medication. This is life-saving medication. I wouldn't stop chemotherapy if she had to go away for 10 days to 2 weeks in order to be safe from being, harmed.
Yeah, I would agree. I've never done 2 weeks, but I have done 1 week if parameters dictate. And in West Kootenays, it can be 3 hours, 2 hours at least from the nearest pharmacy. Of course, they're not open every day, sometimes 3 days a week and so forth. So similar to the opioid use disorder guidelines for OAT, where I know many of us need to fudge the line a little bit. I think that in the grand scale of risk benefit, carries are reasonable in these cases.
Thanks, Tracy and Zach. I also see a question from Al in the chat saying, can we encourage her to move to another city or town where daily dispensing is available?
No. No. That wouldn't be on the top of my list. I don't see that as like a very good option. If she wants to go home to her family where she lives and she feels protected and safe, like that is what I want to help support and encourage. Mm-hmm.
Thanks, Tracy.
Yeah.
Lisa, could we go to the next slide, please? So there's just a few resources here that we hope you're all familiar with. So there's the 24/7 line, which the magic's in the name, it is 24/7. And then there are the risk mitigation update and the opioid use practice update, which are what we talked about today. And then there's also a document that was put out quite early in the pandemic, which was clinical guidance for prescribers and pharmacists regarding OUD specifically. And we will have time for questions, but I just want to note that Jenny was able to join us a bit late, and I wanted to give her a few minutes to speak to her experience with safe supply and risk mitigation and her work as a peer navigator. So Jenny, I'll turn it over to you, and then we'll come back to the questions and comments.
Great. Thank you so much. I'll just quickly acknowledge that I live, work, rest, and play and learn on the unceded traditional territories of Lataco-Dene in what's otherwise known as Quesnel, BC. So yes, Tracy, I believe it was Tracy that shared my slides earlier, and I'm so sorry I came in late. I was trying to get into the Zoom and I'm not very good on computers and it wasn't, I wasn't able to until then. So yeah, that presentation I did a few months ago, and the numbers you like the numbers, the stats, they fluctuate off and on. So the pregnancy one has gone up. We've got about 6 women now, 3 of which have gone into treatment, and 2 still have their children with them. And some other ones are still on the safer supply medications and able to visit their children without being like out of it when they go to see them at the access center, their family home, or wherever they're going. So that's one of the benefits that I'm seeing with the Dilaudid prescribing, and even paired with OUD. So I've had letters from family members thanking me for supporting their family member to get in and get on these meds, because for the first time in 5 years, their adult child is allowed back in the home because they're no longer stealing off them, or in psychosis all the time and getting violent outbursts. So now some of them are living back at home with their family members. Others have gotten jobs and are working. Some are maintaining housing. And when I say success, I don't always mean abstinence. If that's the person's goal, that's great. And there has been about 6 people so far that have gone to treatment, 2 of which have been in there for over a year. One is working at the treatment center. And then I have 2 people with me today who are 2 months off illicit supply. And also one of them is off the safer supply too and just on OUD. And that was their goal. And now they're moving into doing a positive living Quesnel office space. So not only is this helping people reduce overdose deaths, which it also has, because it builds up their tolerance. So a few people I knew were overdosing on a daily basis, sometimes a few times a day. This one girl, every time she used, she went down. Her boyfriend had to save her. And since being on the medications, it's brought their tolerance up to a point where they're not overdosing, even when they do use illicit supply. So I just really wanted to speak to those points. And I'm not sure if you guys seen the quotes from the nurse and doctor when doing the slides. Was that read out, Tracy? Dr. Engelbert?
Mm-hmm.
Oh, great. Thank you so much. Yeah, I just feel it's so important to have people with lived experience doing this work. And the medication delivery has been such, like, I deliver meds to everybody. And it's been such a gap filler, and it's so much better. It's so much easier for people to just get their meds brought to them, especially when they're in entrenched addiction or just coming out of it. It's very hard to keep track of the time of day, the day even, appointment times and all of that. So having a person with an experience that they feel safe with, bringing those meds that the doctor trusts as well, and the pharmacist, bringing those meds to them daily, giving them reminders and rides to their appointments and advocacy in the appointment. It's just been such a huge gap filler. One of the nurses that started doing this with me at the Westside Mental Health and Addictions office had said that the people doubled the amount of people since the peers were brought in to do that work. So they're also able to be, I'm able to tell them it's okay to be honest to the doctor. You don't have to hide the way you use or how much you use or what you use. It's not going to be punitive. They're just going to be able to give you the medications that you actually need to survive and to get by. And so it's really helped with that as well. People are more open to the doctor. They're able to say their own experience as why they do certain actions, why they don't do certain things. So it's been amazing experience for me. The biggest gap that I see is that we're not getting the medications across BC that will fill the biggest gap of all, and that is getting people off the toxic supply. It will not happen until we have the diacetylmorphine and the fentanyl options prescribed. We need these medications to be available to everyone in BC, not just the major cities. And I'm looking forward to the day when the College of Physicians and Surgeons actually supports this life-saving work. I feel like doctors really need that support from the college. And I feel like they're not really getting that, but these guidelines that are being put out, my doctor said today that the updated guidelines, he feels so much more comfortable doing the prescribing and moving forward with the fentanyl prescribing now after reading that. So it's a great start. I just want to say thank you to everybody that's an ally of this work in harm reduction and working towards doing this prescribing. The ways that the doctors and pharmacies are willing to bend. And I know this is so new to a lot of you and even me. But it's what we have to do. The announcement that came out yesterday is going to be worse next year if we don't get these medications out to people. We just have to do it. There's no more choice. There's no more choice. It's this or death, as we see. So I just want to say thank you to all the peers, the advocates, the nurses, the doctors, the healthcare, Northern Health workers, Island Health, all the different health authority workers and healthcare staff. I just want to say thank you so much for even being interested, opening your minds to read about it or hear about it, and supporting this. Like I just and O2. Methadone saved my life. I would not be where I am today. I would be dead without methadone. And I was using heroin for over 25 years. I would never have been able to stop without methadone. I still can't function without it. And it's been 10 years that I haven't used illicit drugs, but every time I go off, I relapse. I an opiate in my brain to function now. And my life is fantastic on this dose that I'm on. I've come down from a very high dose to what I feel is a low dose for me. And I work every day, even weekends. I do self-care. I have my own vehicle. I've been in the same house for 7 years, paying my own bills. I'm a grandmother, a mother. I'm very active volunteer in my community, and methadone has given that to me. And doctors that understand and do client-centered care have given that to me and my fellow peers. And this is life-saving stuff, you know. And I just thank you for listening, and thank you for fighting for this for us.
Thank you so much, Jenny. Really powerful words, and I always learn so much listening to you speak. There's a question for you, Jenny, from Stacy, which is, have there been any issues with safety while delivering to patients? Do you deliver alone or with another individual?
So I do have a big lockbox in my van, and I go out with my partner, who is who is the person I'm kind of mentoring into this role to help me. And he comes out with me every day. There's always somebody in the van, and I do the 2 big buildings first. So I'm not carrying a lot of medication. So I go right directly from the pharmacy to our shelter and the supportive housing building. And then I go to the homes where I don't have very many medications on me at that time. And I'm pretty respected and well liked here. Like, they're pretty protective over me, the peers here. So I'm not worried about that. They know I'll help them with a couple of bucks if they're sick and stuff. I've just never been worried about that. I still be careful though.
Thanks, Jenny. Are there other questions about any of the pieces we've talked about today?
From me?
From anybody.
Oh, okay.
We've covered a lot. And just noting a comment from Sharon. Thank you, Jenny, for sharing your knowledge.
Thank you, everybody, for inviting me here today. And again, my apologies for being late. It was not intentional at all. And thank you, Tracy, for sharing my slides.
You would have done it better.
Hey, recognizing that it is almost 6:30. Oh, we've got a comment from Jeff. Can anyone talk about co-prescribing benzos and opioids? It was mentioned earlier that this is ill-advised, but seems to be a practice that would benefit many.
That's one of the barriers that we also face too. A lot of people will go back to the illicit supply because they're in benzo withdrawal. Even though they do have the opiate medications that they need, that they're not getting the benzos. So it's a pretty horrific withdrawal. I really wish that we could do that here. Even a low dose for a few days would be helpful just to get over the main detox days, you know. So I really hope that comes, but I do understand the concern behind that as well. I don't want to see anybody overdose either. I just think that it's safer to do that than to leave people to go back to illicit supply.
I'll comment briefly on that. The down supply has been adulterated with benzos for months and months now, and I was surprised for how long I didn't seem to notice, at least for people wanting to go on OAT. It seemed to we'd seem to not need to worry about recognizing the benzos. We would just do an induction and titrate, and it seemed to be okay. I figured that, you know, as I was going up on the OAT dose, their fentanyl with benzos use was going down at a gradual enough speed that they were kind of doing their own self-taper. But I would say in the last 3-4 months, there must be the benzo content has increased. I don't know, but it started by getting up to close to a therapeutic dose of an OAT, but still, I just can't seem to shake that last point or two. Keep going up, still that point or two. I'm like, okay, I think I could go up forever, and I'm not going to wipe out that last couple points of fentanyl. So I have started doing a benzo taper in those cases over a couple of weeks, and that seems to be enough to wipe out that last bit. Yeah, I mean, as far as longer maintenance prescription of benzos, I'm still pretty shy against doing that, but absolutely, I think that it's entirely reasonable to do a benzo taper.
Thank you, Zach and Jenny. And I see Danielle Razor has a question about Cadian start dose. Danielle, do you want to come off of mute and share your question?
Yeah, and I'm glad to hear that last comment on benzos, because I have had to do a benzo safe supply prescription and taper for some clients that just are having trouble, because when they go on methadone, then they're not getting those benzos. So it's good to have that reassurance. So my question about the Cadian start dose was from the earlier presentation. I had been using more of a rapid titration that was if the clients had been on Cadian before, within the last, I think it was 14 months, it had said. This had come from the Downtown East Side a long time ago. And we were starting at 300 for clients who had known Cadian tolerance. Is that still Like, have we gone back down to 200, or is there exceptions if they've recently been on Cadian and we were doing a restart?
I'll try to answer that. I think if you can motivate your reason, and that being said, it's recently been on Cadian with tolerance. I mean, I personally haven't done that, but I do think be clear in your motivation why you're doing it. I would be more inclined to do it in a more of a safer setting. I mean, as I said, in a hospital, as long as you have a good motivation for it.
For me, sorry, Tracy, if they have just fallen off the program and they were quite high, and it's just I will start at 300 sometimes, but generally I do still start at 200 even for them, but I'll do a pretty rapid up titration of 100 milligrams daily, as long as I'm keeping a close eye on them. So yeah, 300, I guess I'm cheating them out of a day with that schedule, but I think it is safer.
I just wanted to let you guys know, like, another thing that we do here, we have a Renner House, detox house in Williams Lake, and we are able to bring clients there to do rapid increase on both OUD and safer supply, which OUD or safer supply includes Cadian. It's on both lists. So the doctor will put them in there for like 4 or 5 days, and they're able to get up to a pretty comfortable dose in that time. Maybe 6 days. And also they allow couples to go too, which is really great. A lot more people are going now that they can go together.
To go further with your question, Danielle, depending on the patients that I have, I usually would start Cadian at 300. And if they've recently been on, then 400, and then increase by 200 milligrams daily, depending on how much they're using. So, I mean, there are smaller scales, but that's usually the max that I would kind of do.
Thanks, everyone. That's really helpful. Yeah, our clients are seen quite often because that we have a shelter where our ICM team visits every day. So they kind of report back to us pretty frequently as well. So it allows us some at least they're having someone go and assess them.
Mm-hmm. I think the other thing is, when you're doing those rapid and hefty kind of titrations, like having really good relationships with your pharmacy colleagues is so important. Like one of the pharmacies in Prince George, they're like so stellar to work with. And when there's like complex patients that come in with rapid and high titrations, like there's usually a phone call and communications going back and forth about this kind of thing. And, I actually don't know where half the patients would be if that pharmacy wasn't doing the things that they're doing.
Great question. Thanks, Danielle. We have time for a couple more questions if folks have burning thoughts. Okay, seeing none, I will do the time-honored tradition of starting to wrap up, and I know something brilliant will strike you, so pop it in the chat if you want. But otherwise, I will thank everyone for their thoughtful questions and attention, and the work that you're all doing in a really challenging time. We will be sending out the documents and the webinar slides in the next couple of days. And I'd just like to plug again the 24/7 line if you're needing to ask an addiction expert about a complex case. So thank you all. I'll wish you a wonderful evening and a weekend when you get there. And a big thank you to our 4 presenters as well, Tracy, Anke, Zach, and Jenny. Thank you so much.
Thanks, everybody. Bye for now.